You are listening to Prevention is the New Cure, all things health and politics, with myself, Steve Bryan MP.
And with me, Lord Bethell, James Bethell.
Hi, James.
How are you, Steve?
Nice to see you. Let me just explain to those who listen to this. The good doctor, is not in the house. So Helen Stokes-Lampard, Dr. Stokes-Lampard, who's normally with me for the podcast, is overseas at the moment. So she's away, a bit like Santa during the off-season. She's away, so she will be back next time. But we're absolutely delighted that my lord, James Bethell, is with us, who's a fellow traveller on all of these issues. And we're going to talk about some of the things you're involved in your campaigning and professional life. But before that, we thought we'd just whiz through some of the stories that are going around in health and politics at the moment. We thought we'd kick off with the King, talk a bit about GPs and sick note culture, which the Prime Minister was talking about in the last few weeks, a bit about measles, some story I've spotted on that. And then I know you want to talk about smartphones and kids. So does that sound like a plan?
That sounds fantastic. Thanks very much indeed.
So, as we record this, it's a Tuesday afternoon, which is the last day of April. And so last week, the King had announced that the return of the King, I think a lot of the front pages had. And obviously, he's back on public engagements today, which is just fantastic to see. And he's been visiting a cancer centre in London. You caught this, I guess, on the news.
I did indeed. What an amazing story. And the idea that the King is now aligned with the prevention agenda is incredibly encouraging, right?
Yeah, well, I think he was already a patron for Macmillan, wasn't he? But he's been named today as Cancer Research UK's new patron, and he went to this centre. And I just sort of highlighted this quote. He emphasising the importance of cancer checks. He said, "The challenge is, quotes, to get enough people early."
I know.
The
well,
King's nailed it.
He's totally. He's absolutely on the money, and shouldn't that be the mission? I mean, that is what we've got to try and do, to pivot towards that kind of early intervention agenda, because we rely too much on people staggering into A&E within terrible state, and it costs an absolute fortune, and they never really fully recover if we only catch them late in the day.
Yeah, of course. And we don't know what cancer he's being treated for, which he's still being treated for. But we do know, because the palace said this, that it was picked up during a procedure for something else, which is so often the story, isn't it?
It is. And I think that there is a back problem to this, to be honest, Steve, which is he does have the resources available to him of being able to pay for early diagnosis and to take every single test possible when needed. Now, I think that there's an opportunity on a wider population basis through the NHS for this kind of approach to be available to the whole of the tax-paying public and to NHS patients. And I think it probably has an enormous return on investment. He is leading the way in this respect, but he is leading the way as really a private patient. That's not to say that it's not valid, but it is a shame that isn't more widely available at the moment.
Yeah, when we were with the select committee in Singapore last year, and we obviously as part of our future cancer inquiry, one of the guys that we met over there said to us, look, our mission is to prevent it, and if we can't prevent it, we want to find it early, and when we find it, we want to treat it well. I thought, yes. What a brilliant way of putting it.
Yeah,
absolutely spot on, isn't it?
But it is. But I'm afraid not all clinicians feel like that. A lot of clinicians think that the way to ration resources most effectively to get the highest return on investment for our clinical expenditure is to dedicate the largest amount of resource to the illest people. And that often means the people who are stumbling in with the worst symptoms. That's the old-fashioned way of doing things. So your clinician, I think, is very progressive, but it's not necessarily the mainstream view.
No, it's interesting, isn't it? And I suppose a sort of link to that is this other story that's been kicking around today, which I noticed actually that you tweeted about it earlier. NHS England needs 3 more years to recover from COVID, said Richard Meddings, who of course is the chair of NHS England. Did you spot that story?
I did. I've spoken to Richard about this a few times. He has definitely brought the prevention agenda big time. He talks very movingly about the vast stock of morbidity we have in the population already, and the struggle the NHS has to to cope with all of that. And there's just no way that we're going to have the resources necessary to operate this model on its current form of just waiting until people have got a load of diseases and then to try and deal with them in a complex manner. So he has definitely got round to thinking that more priority needs to catch a disease earlier, to treat it at a much earlier stage, and that's the only economic way that the system can be viable.
Yeah, I mean, he said, he said it'll be a struggle to meet demand fueled by, quotes, the behaviors of a modern world, including gambling and consumption of ultra processed food. But of course, if you then look at the comments on the tweet from this, including from yours, what you've got a lot of people weighing in is sort of saying, well, okay, Mr. Meddings needs to transform the service to be much more preventative, and we're spending money at the acute end and not at the front end in primary care and not on prevention, and that's the trouble, isn't it? NHS England are open, I guess, to that charge, but then nobody in the acute sector is saying, can we have less?
Exactly. I know. Well, how we pay for the pivot to prevention is a real conundrum. There's a dual running cost there of trying to find enough resources to stem the flow whilst also looking after the current stock. And we're going to need to look to other sources of funding in order to pay for that transformation. It can't all come from the current NHS budget because it's just not enough money to pay for it all. I think that's a subject that we should go into at one time.
Yeah, no, definitely. I mean, you and I speak. We often sort of plough the same field, don't we? And we speak at events. And I said this in the house when we were doing the smoking debate. And there were, as you know, there were a number of people
Mm.
on our benches who were speaking against this. And I said then, I don't see how, if you're a conservative, you couldn't be in favour of the smoking policy, for instance, because smoking ultimately leads to people in the acute sector. It leads to a bigger acute sector. It leads to people needing the state more, costing the state more. The true conservative policy, if you want to take it on those lines, as some of those opposing it did, would be to tackle the causes of ill health, because it means that they need the state more, they need the hospitals less, and surely that would be a true small c conservative way to tackle this.
Absolutely. And you're right. It just drives me nuts to think that there are people who are wringing their hands about the massive costs we're putting into the NHS, but they aren't creative enough or thoughtful enough to think about how we stop that flow of ill people. And smoking is such a classic example. It's still 13% of the country, particularly concentrated amongst the poorer groups, and particularly concentrated amongst people who've got many other morbidities as well, the obesity, the poor hearts, the respiratory diseases. If we banned smoking tomorrow, we would have a considerably healthier country by Christmas. Now, I'm not putting that on the table, but it is worth thinking about the consequences, financial and clinical consequences of supporting the smoking industry in this way. And it is time we moved on. And that raises a similar question with junk food, with the moldy air, and with many of the other pollutants we've got in society that are costing us a huge amount of money.
What did you make of the smoking debate up our end then? Because obviously, we did just so
Yeah.
people understand the process, we did second reading, which is when you give the bill yay or nay, and we gave it a yay. And now it goes into committee stage. And actually, I've been this morning, Tuesday morning, watching a bit of the committee stage, because they're doing these sort of evidence
Mm.
sessions at the moment where they've got, they had Michelle from Cancer Research UK and Deborah Arnott from ASH in this morning, and people from teaching unions talking about all different bits of the smoking and the vapes bill. It'll then go into committee where they do line by line stage before it comes back to the House of Commons for a sort of report stage and third reading. And then it comes to your house in the House of Lords. What do you think will be the response in the Lords to this bill?
Well, I saw some of the Commons debate. I missed your speech, which was famously the best speech, of course, Steve. So I apologize for that. I was really struck that it was really seen through the lens of the leadership struggle, and a lot of the speeches in the Commons were really not substantive speeches about the measures at all. They were people having a crack at the Rishi Sunak leadership, which I thought was both a shame, because I take public health very seriously, but also indicative that this measure does have a huge amount of support and people aren't trying to pick holes in it. When it comes down to our end, I think that people will be much more detailed in their scrutiny of the implementation measures, which are important to get right. I think that they all have answers to them, and we will be fine-tuning things. I think there will be people who add amendments that go further than the current bill. The Khan review had a total of 17 recommendations, some of which would be very useful additions to what's already in the bill. For instance, the regulation of vape and cigarette retail outlets. It's very tricky to maintain the measures that are in the bill without that regulation. I don't think that they will prevail. They won't. I don't think they will be added in the end, but I think that that will itself be a very, very interesting debate. There'll also,
Yeah,
there'll also be a debate about whether, instead of having a ratchet age that is a sort of endless ratchet on the age, whether there should be an age stop at, say, 25. Again, I don't think that that will prevail, but that is an important discussion to have, and one that will get a good airing in the Lords for sure.
well, that is interesting because I know that one of the MPs in the bill committee has already put in an amendment for,
Right.
and if you remember that the campaign 21 Now, which was Ash's sort of campaign for a while, and then the Khan review with the evidence led to the smoke-free generation, where you just ratchet the age year on year. So no one who is my son's age, 13, born after 1st of January 2009, will ever be able to legally buy cigarettes. But the 21 Now campaign, somebody's actually put down an amendment at the Commons Committee stage for that. So it'd be interesting. You say that that might come up again at your end, and I can see how it will. But I don't think, for the reasons Khan set out in his review, I don't think that will skin that particular cat. I think the way that we're going for the smoke-free generation, there's a clue in the name, isn't there?
Exactly. It's such a big and emphatic vision to eradicate smoking altogether, and obviously it's such a big Prime Minister's legacy project. No one's going to want to see that watered down. I also think it's inspiring in a positive way for people who are trying to tackle other public health challenges, whether that's obesity, respiratory disease, gambling, and the others. The idea that you can fix some things, and actually we can have a better society. I mean, I'm hopeful that in 30 years' time, people will be leading much healthier, longer lives, and it's through measures like this that we'll get there.
Yeah, it's interesting because you mentioned obesity, and I suppose one of the arguments that I've heard around the tea room table with colleagues is, okay, they're after the smokers, and then what will it be next? Where will they go next? And if you listen to the speech of, I tried not to, but I was waiting to be called. If you listen to the speech of Liz Truss, she kept referring to big health. Which was sort of like a riff on big state and, here we go, nanny state, finger wagging, telling people what to do, banning things. That's the great fear, is to where next. And I don't shy away from that, because ultimately there needs to be a next, doesn't there? So we did the sugar tax because we need to take sugar out of food. We really need to take quite a lot of salt out of food, don't we, as well? Because that might actually prevent quite a lot of strokes. And I would have thought that's quite a good thing as well.
Yes, there were two big ironies to her speech. She talked about the health police a lot, but actually we've completely disbanded the health police, got rid of PHE, pretty much got rid of OHID. UXA is defanged, and it isn't the kind of heavyweight, hefty Whitehall enforcement team that we had originally envisaged it. Local authority public health resources are very, very denigrated. I think all of these things are a great shame, but the idea that the health police gone mad is just not true. The other thing is that the public strongly support the measures you just listed. If you look individually at the sugar tax, at the gambling profits levy, if you look at overall in central London on ULEZ, I think less so in the donut, but if you look at a sugar tax that took Siddle further, and if you look at the smoke-free generation bill, strong public support in the 70s and the 80s on many of them. And that just reinforces what we learned in COVID, which is that the public are thoughtful about public health. They do want to see their children protected and their parents living for longer, and they are worried about their own personal health. And a lot of these interventions are really, really popular. It's something that the Downing Street machine has twigged onto, and their approach to smartphones and the potential smartphone restrictions for under 16s, which I hope we'll get a chance to talk about, I think is a reflection on that.
Yeah, no, we definitely will. Anyway, we went right off down a smoking bill tangent there, which I do tend to do quite a lot, as Helen will tell you. Listen, can we talk about GPs? I said at the start. So the Prime Minister announced plans to trial stripping GPs of their power to sign people off work. He attacked what he called the UK's sick note culture in a big speech about welfare the other day. Instead, he wants specialist work and health professionals to issue fit notes as part of a broader aim to make sick notes harder to obtain. Now, the BMA said that the Prime Minister's rhetoric was hostile. And today, Professor Camilla Hawthorne, who you will know as I do, chair of the Royal College GPs, told Radio 4's Today programme that as a profession, we're not against the idea because of high workloads, but pointed out that issuing fit notes often formed part of a wider consultation with a patient. I know what Helen would say if she was here because we've exchanged messages about it since the speech. What do you think about this sick note culture speech the Prime Minister made the other day?
Well, listen, you've got to disentangle a little bit from the substance and the rhetoric. Mel Stride is trying to wrestle, I think, with a difficult situation, which is that a lot of people who go to their GPs are simply signed off 94% without any support or further intervention. And that just doesn't make sense. It doesn't make sense from a clinical point of view that people who are too poorly to go to work aren't getting any support at all. And it doesn't make any sense from an economic point of view. And he is bringing in measures like the Work Well measure to try to bundle both welfare and clinical support for people, which it's tricky to do these packages. But I believe that in their sincerity between DWP and DHSC to try and coordinate in order to package up better support for complex needs from people who might, for instance, have a number of problems, including health and workplace issues. So that bit of it, the benign bit, I am a massive supporter of, and that's really what the substance of the policy underlining was about. So good luck to them. I have some question marks about the actual amount of money that's going into it and where the people are who are going to actually deliver this, but the vision and the problem diagnosis is about right. But then you get this political kicker, in an election period, that's demonizing people who are turning up to GPs with problems. And by the way, most people who've got a mental health issue have got a physical problem as well. Most people have got multimorbidity. So although they might have a tick against the mental health issue, they may well have cardiovascular, respiratory, muscular, skeletal. So of the people who have dropped out of the workforce, the average is between 3 and 4 morbidities each. So only one of them can be mental health at any one time. Now, what are we going to do about that? That is the big question. Demonizing people who are ill makes no political or financial sense. Anyone who's got a loved one who is actually wrestling with their health is going to react very badly to that kind of rhetoric. It might work well in the Daily Express, but that's not what people's lived experience is at the moment. And it's definitely not going to tackle this big dropout from the workplace we've had. 500,000, well, nearly 700,000 now who've gone onto the long-term sick list. That's the really big issue. And we should be talking much more about what's driving that big economic disaster and how we're going to treat our way out of it. Most of the people on the long-term sick list are never, ever going to come off. And we're all worried that there's going to be another 500,000 that drop onto it if we don't do anything about it.
Yeah. So the bigger picture, and I think the Chancellor would certainly agree. And anyway, and the comments you made fit well with what Camilla Hawthorne's saying about, hold on, because GPs look at this as part of a wider holistic view as to what they're doing with their patient, and maybe that's why they issue the sick notes. Anyway, let's take a quick break, and then we'll come back. Okay, welcome back. This is Steve Brine, MP. I chair the Health and Social Care Select Committee in the House of Commons. This is Prevention is the New Cure, our podcast, and delighted that Lord James Bethell is joining me today. Helen's away. A couple other things, James. We on the Select Committee are doing this prevention inquiry at the moment, as you know, and the first work stream, no coincidence, because it's the biggest intervention you can make on population prevention other than clean water, which is vaccination. So this fascinating story that caught my eye today, that's all over the news, a vaccine patch could be a safe and effective alternative way to protect young children against measles, a trial in the Gambia. So basically what this is, it's the size of a sticking plaster, and it's easier obviously to transport and to store than standard injections are, especially in remote areas of Africa. Measles is a very contagious disease, very common in children, can actually kill. And it's a it's a really interesting patch that goes on the child's arm in replacement for a needle-based vaccination. What do you reckon?
I'm unbelievably excited about that. And there are two big reasons for that. I was involved in the vaccine program during the early stage of COVID, and I spent a lot
Yeah.
of time looking for fridges. And the transport, we became the biggest fridge owner in Europe at one point. The transportation of vaccines is a massive headache. Some of them, like the Pfizer vaccine, have to be kept very, very cold. Even the AstraZeneca vaccine is quite tricky to move around. Once you open one of those bottles, you have to use the contents very, very quickly. That has all sorts of practical problems, particularly in the outback. So moving around vaccines is a huge headache, particularly in the developing world. So if you can solve for that, that's great. And then secondly, a lot of people don't like injections. I mean, I'm not a big fan. I wince. I don't particularly like it. I rough it out. But if people are looking for a reason not to have a vaccine, then fear of injections is a good one. That's why we spend a lot of time looking at sprays. You can spray vaccines, and some vaccines do have a spray alternative. Others are looking at growing vaccines essentially on plants and then making paper out of them so that they can be chewed instead of being injected. I think that this is all great progress, and anything that can make taking a vaccine easier is got to be good for the world, and is
Yeah.
often quite a lot cheaper as well.
Yeah, that's interesting. It's called the microarray patch. It sort of sticks to the arm,
Yeah,
is what it's saying. And then lots of microscopic needles deliver the vaccine through the skin, but virtually pain-free. So they've done a trial of about 200 healthy toddlers and babies, and apparently the immune response is as strong as the jab. So, hopefully they hope the patch stays there for about 5 minutes, but that will come down to a minute or less.
Great.
And hopefully it will be used against other diseases in the future. So I thought that was great. Anyway, you want to talk about smartphones, which is really interesting to me as a parent of teenagers. What do you know?
Well, we've got Jonathan Haidt in town this week, and what he has done that's interesting is to build on the instinctive worry of a lot of parents that the time spent by our kids on smartphones is not good for them, and turned it into science. And he has looked really carefully at the impact, particularly since 2012, when Apple put a camera on the other side of the phone, so you could take a photo of yourself. That's the moment. That's the operational tweak that suddenly turned basically a speaking device into something that was fit for social media. And he's looked at the huge impact that's had, particularly on the mental health of kids, but also on their educational attainment, their physical activity, their attention span, their happiness, and their loneliness. And it fits into a broader discussion that he's made, which is about childhood and the reduction in trust amongst parents in allowing their kids to be out and about playing and really fulfilling the needs of a sort of childhood playful system of discovery and risk taking. And it looks at specifically the role of mobile phones in breaking that up.
No, that's really interesting. Policy Exchange done a piece of work on this, and sort of on the schools angle, which I'd be really interested to get your view on. So that in schools that had effective phone bans, GCSE scores were 1 or 2 grades higher. Now, okay, so we'd have to look into the workings out behind that piece of work. But what do you think about this whole issue then about schools, smartphones being in lockable phone pouches in lockers? Teaching unions have all sorts of issues with teachers handling phones.
Yeah.
This is not as straightforward as some people make out, is it?
Well, it isn't. It. You're right. It is and it isn't. So three quick points. We have the data that Policy Exchange got back was the best data we've got, but you're right. It's still a little bit sketchy, but it points to what instinctively we would think correct, which is the areas of greatest deprivation and the areas with the poorest outcomes in the first place also have the worst phone behaviors and also have the greatest impact of phone, or would seem to have the worst impact of the phones on their educational outcomes. So this is a subject that, once again, as with obesity, it is the least fortunate who are hit hardest by the problem. Secondly, in terms of phone usage, probably the biggest problem really with the phones is that kids are spending 8 hours a day on the phone. I mean, yeah, sure. What they're watching is often the content is terrible. It includes very often horrible, violent, misogynistic porn. And yes, the predators are a big problem. and the algorithms screw with their brains. Those are three really big problems. But it's the sheer quantity of numbers that there's time that
It's
they're
so
not spent.
true. I'm told the average child receives 237 notifications a day, one every 4 minutes of waking time. Now,
I know.
I have a
Yep.
13-year-old at home and a 16-year-old. It's a lot easier to moderate the 13-year-old, although that's becoming a battle too. But I sometimes take his phone off him and I put it in my pocket, and it's constant. It's constant buzzing in my pocket. I mean, I thought I get a lot of messages, but I mean, goodness knows. And when he's been on that phone, I call it grogginess. There is just a grogginess to him,
Yep.
which when he's not on it, I see a different child. And
Yep.
who knows we talk about vaping, don't we? Who knows about the long-term impact that's having on rewiring brains?
I think that's right, and the loneliness. Snapchat is meant to connect you with other people, but it keeps you at home really, and it makes you feel very lonely. And John Haight's view is that this may have a substantial long-term issue. The years of puberty, in particular between 10 and 13, is when our brains are wired. That's when we learn the social skills, the ability to problem solve, the ability to collaborate with one another, to endure stress and setback. If you spent all that time gaming and watching YouTube back to back, or running three devices at the same time, which is what a lot of kids do, you're missing out on some of the fundamental wiring of your brain that's going to prepare you for the rest of your life, and it's very difficult to repair that. So I think this thing about the school, listen, there's a broader problem with the sheer amount of time and what people are doing on their phones. And schools is, I think, the battleground for this, because clearly there's no role for people fiddling around with their phones, and it destroys the collaborative teaching didactic method of schools if people are distracted and really only half paying attention to their lessons and to their fellow kids. So I think there's going to be a big drive to get phones out of schools, and not just, by the way, in the pocket or in the rucksack, literally checked in to a locker at the beginning of the school day and released at the end of the school day. That's what really makes a big difference. And one of the people that we're going to have to persuade on this is parents, who have become very, very risk adverse, because the phone thing hasn't happened in isolation. What's happened is parents were already becoming very, very risk averse about the way in which their children play, go out to the shops, go out into the street, very worried about predators and danger. And the phones have played into that situation, and parents themselves want surveillance of their kids and to know where they are. So we've got to somehow address that
Yeah,
quite
but
dangerous nexus as well.
here's the thing with the handing in. So you've got to have the infrastructure, of course, to do it.
Mm-hmm.
And my concern is, you talk to some head teachers about this and in my constituency, and they say, well, okay, so let's say somehow we had the capacity to queue them, hand it in, tutor in the morning and put it away somewhere and store it safely. Then, they're going to hand in the smartphone and keep something else, keep another device, or hand in a brick and keep the smartphone in the bag, or you're going to search bags. And then you've got all sorts of issues where and then of course, like my son's school, they have tutor in the morning, they don't have tutor at the end of the day, so how would they have it back? I think the practical considerations the teaching profession would say, I'm just playing devil's advocate here, is that what do you want from us? You want us to do the 3 R's, you want us to do this, you want us to do that, and now you want us to do this.
But Steve, your points are all fair, and ultimately this is about culture and norms. You've got to create a different normal behavior where people just don't have their phone. By the way, they don't take their clothes off in the middle of class, and they don't light a cigarette or behave badly. But we've got to try and make it easier for people, and we've got to create a clear signal. So all of those problems I completely acknowledge are right. And some parents may even resent the fact that we're taking phones off kids when they go into school because they want to stay in touch with them. But we've got to somehow make the right choice the easiest choice. But that won't happen with wishy-washy half measures or by fooling ourselves that kids are going to be sitting in class with the phone in their pocket, completely ignoring the phone, because that clearly isn't working at all.
Well, that's great. Let's take a break and then we'll come back and talk about business for health. So, James, Business for Health is one of your many projects. It's really interesting. I've been looking it up online. People want to find out about it. It's businessforhealth.org. Tell us what it's all about.
Thank you, Steve. It's a recognition by many of the UK businesses that the health of our workforce is absolutely fundamental to the economic viability of our country, and that businesses themselves have a huge impact on people's personal health. So what you do in your work life, whether that's through the environment that you work in, or physically through your commute and your gym, or through the support you get when you inevitably hit the bumps and lumps of life, is just really, really important. And businesses are in a great position to be able to support people who need it, and also to ensure that they themselves are creating the right kind of environment for people to make the right healthy decisions.
Ah, really interesting, and you've got quite an interesting bunch of people that are involved with it. And presumably you go out and, as Matt Hancock, former Secretary of State, has spoken about it. You go out and speak at events, presumably, do you?
It's partly speaking events, but to be honest, the a lot of the work is done with the businesses and the business panel themselves. We've got some very enlightened businesses like Vitality and AXA and Legal and General who are themselves really leaning in on issues like occupational health and fair sickness pay for workers. And there's a lot of engagement with Treasury and DWP and the HSC on trying to make sure that the regulations are in place and the financial support is in place to be able to improve the way we do these things. I don't think we have a great track record here in the UK. We have, as you know, 2.8 million people on long-term sick at the moment, and we've got a really big mental health epidemic, really. It's not fully understood, but one thing I do know is that businesses are both part of the problem and also a big part of the solution.
Yeah, no, well, fascinating. We'll put a link to it, or we'll tag it in when we put this episode out on social media. Anyway, let's hit the pod surgery button, James, and you can be involved in the madness that is pod surgery. Okay, right. Couple to go through before we wrap up. Dear Stephen Helen, replace Helen for James. As co-chair of the Community Rehab Alliance, made up of 60 health and social care professional bodies and patient charities convened by the Chartered Society of Physiotherapy, we welcome your upcoming podcast on Preventionist New Cure. We hope you will include as part of this the increased recognition from decision makers everywhere that rehab is as important as medicines and surgery. I know Lord Bethell has long recognized the importance of rehab. Over to you, sir.
Yeah, I strongly agree with this one. We are good at stitching people up and dealing with their lumps and bumps. We are not good when it comes to sending them home. I mean, the image we have is of putting someone in an Uber with their hospital notes sellotaped to their chest with no care package when they get home. And the result of that is people don't fully recover. Too often they boomerang back into hospital with either the same or related complaints, and their journey back into productive life, whatever that is, in the workforce, supporting their loved ones or whatever it is just takes too long and sometimes is incomplete. When you look, for instance, at the statistics for mental health and also for MSK, very often it's been a incomplete medical intervention that's really begun the odyssey of complaint. And we've stripped that bit out of the health budget in order to pay for the acute care that people get. But it's a very short-sighted strategy, and we really need to wake up and sort that out.
Yeah, cool. Okay, that was from Sarah Hazard. She says in her email, after all, acute saves lives, rehab saves people. I like that.
Yeah, nice. Put it very well.
Anyway, one more. This is from Charlotte Nichols at Macmillan. Dear Stephen Helen, I'm Charlotte, head of influencing at the Richmond Group of Charities. I love that. I want that on my business card. Head of influencing, a coalition of 12 leading national health and care charities. I'd be really interested to hear yours and Lord Bethell's perspective on how the health system should adapt to account for the growing numbers of people living, often for decades, with multiple long-term conditions. So we talked about this a bit earlier on, didn't we, in the podcast? And the government will bring out, well, who knows when, it's major condition strategy, which is about exactly this and is controversial for all sorts of reasons. But what do we think then? How should the health and care system adapt for the growing number of people living with many different comorbidities?
Yeah, it's a fundamental problem, and it's so complicated. I mean, anyone who's had a loved one who has multiple morbidities knows they all relate to each other. You need different specialists for different things. You need different diagnostics and treatments, and the treatments for one affect the performance of another. It's the modern malaise that's hitting Britain in particular really, really hard. I think that there are two things that need to be done. One is we obviously need to pick them off individually. So the underlying poor health from things like obesity, respiratory illness, stress need to be reduced so that people don't have the morbidities piling up. And secondly, we have to give patients, I think, much more influence in their own treatment and medication, because with a lot of these complicated cases, the patients themselves actually understand their own treatment and medication more than a big committee of often uncoordinated clinicians who don't necessarily fully understand all of it, particularly when there are people who are outside the healthcare system involved, maybe in trying to improve things like housing or education or child support.
Yeah, yeah, amen to that. And I suppose all I'd add to that is I expect multi-morbidity, as Chris Whitty calls it in his current annual report,
Yeah.
when he talks quite a lot about this, is probably linked inextricably, isn't it, to health inequalities. So if you live in a deprived community, you've got a reduced life expectancy, which is in itself an absolute scandal. But you're probably finding that more people there are living with these multi-morbidities than in the wealthier communities. So it's a social justice issue, isn't it, as much as anything?
It is, and I think also the other thing that Chris points to quite emphatically is that the underlying condition that causes the diseases is often one or two things. It is things like the obesity and the hypertension that people are living with that triggers a number of different physical responses, that triggers the high blood pressure, the cardiovascular disease, the diabetes, the musculoskeletal. A lot of musculoskeletal is people who are carrying too much weight. A lot of cardiovascular is people who are carrying too much weight. So, and that does correlate very heavily with deprivation and with poverty. So, yeah, these things, the root causes are pretty simple. It is often poverty and obesity.
Yeah. Yeah, they've got something called the 1 in 4 manifesto. We'll pop the links to it up on the social media. Listen, just to wrap up there, it's been absolute pleasure to have you on the podcast. Helen sends her regards. Just sort of looking ahead before we close then, obviously there is going to be a general election this year. There is a possibility, he says cheekily, that there could be a change of government. Do you think that what do you think this government in all its incarnations, what do you reckon the scorecard will be of our government in the, let's say it's 14 plus years that we have in office? What do you think the scorecard will be on how seriously we take in prevention? Let's be honest.
So you've got to look at the problem across the piece. All countries in the developing world are wrestling with a lot of the same problems. We are not unique, but we have done worse than most, I think. And I think that it's been a real struggle for a Conservative government to make tough decisions around system transformation, to divert resources from acute care to put it into prevention, and to tackle some of the behavior change needed to underpin healthy lifestyles. I think we've really, really struggled. Maybe it's a Nixon to China problem that we just took on board the advice from clinicians, mainly dominated by acute clinicians, that what was needed was more doctors, more nurses, more medicine, more hospitals. If you thought that was going to be the solution, then the Tories have done a lot. But I don't think you can treat yourself into good health. And actually, the scorecard's very bad on what we've done on prevention.
Yeah, I would agree. And I suppose, looking forward, it's probably the next government of whatever color that is going to have to grip big data. It's going to have to grip health service data. And, we always don't sell NHS data, use it. And if we do that and the NHS behaves as an insurance system, which in fact is a national insurance system, right? That's what we used to call it. Then we could get upstream of individual personalized health, individual personalized prevention. And that's surely got to be where the next health secretary, whoever that is, takes it.
I agree.
Listen, it's been an absolute pleasure to have you on the podcast. Thank you so much. If you want to send comments, we're obviously pleased to hear that. We're across all the different social media channels, and you can email podcast@stevebrine.com. And where do people find you on socials, James?
I'm on Jim Bethell on Twitter and Lord Bethell on LinkedIn.
Brilliant. Okay. Until next time, we'll see you.
Fantastic. Thanks, Steve.
Bye.